Welcome once again to our online Zoom tutorials. Today we are starting with pharmacology base. All right. So we have a 30-year-old patient complain about having abdominal pain and diarrhea for 5 days. So there's abdominal pain and there's diarrhea. Temperature is 37.5 degrees Celsius along with chills. So over here, you are thinking of a problem with the what? With the intestine. So you're thinking of enteritis or gastroenteritis. Gastroenteritis. And they said the day before, the patient had been in a forest and drank from an open water reservoir. So obviously, this person could have taken in some contaminated water. Okay, that is leading to the loose stool and then the abdominal cramps or the abdominal pains. Of course, with temperature means there's an infection taking place. That's why I said we could diagnose this as what? As a gastroenteritis. And to be specific, over here, they are telling you that what? The diagnosis is what? Amoebic dysentery. Amoebic dysentery or amoebiasis. Amoebic dysentery. So what is the drug of choice for this patient? So you are looking for a drug. So you know that amoeba is not actually a bacteria, but rather what? A protozoa. Right? So you are looking for anti-protozoa what? Drug for this particular what? Patient. You are looking for anti-protozoa what? Drug. And that's why over here, your answer can easily go in for what? Metro. Please kindly mute your microphone. Otherwise, to be disturbing the rest of us. Thank you. So over here, we quickly go in for what? Metronidazole. Metronidazole. And metronidazole is both bactericidal at the same time anti-protozoa. Anti-protozoa. So you can write this down. It is used to treat Giardia, Giardia. 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 It is used to treat entamoeba. It is used for trichomonas. Trichomonas. It is used for vaginalis. Vaginalis. So all of these things are agents that metronidazole can effectively eradicate from the system. And again, it is used in a combined therapy to treat Helicobacter pylori. You know, Helicobacter causes what? Ulcer, right? So it can be used in conjunction with other therapies or other drugs for the treatment of Helicobacter pylori or ulcer. So obviously, like I said, since this is what? Amoeba, and we said metronidazole is antiprotozoa, definitely your answer is what? Is C. Is C. Please mute your microphone. I'm seeing some people's microphone are still on. Kindly mute it. Otherwise, it will be a distraction for some people. Okay, so we continue. We have a woman who works. Please, can we mute our microphones? Let's mute our microphones, please. Dr. Omar, please, your microphone. Dr. Omar, thank you. All right. Thank you. So we have a woman who works as a railway traffic controller. She suffers from seasonal vacuomotive rhinitis. That means this sort of rhinitis do not occur every single day, but rather it is what? Seasonal. It is seasonal. So you could be thinking of somebody with what? Allergy. So this is somebody suffering from what? Allergic reaction. Allergic reaction. And they said this person gets treatment in the outpatient setting, meaning he was not admitted at the hospital. It was outpatiently. So she was prescribed an antihistamine. Oh, please, our microphones. Thank you. Okay. So we are looking for what? An antihistamine. Of course. Guys, forgive me. Today's the first day, so these things are bound to happen. Okay, because many people don't know the rules. But basically, when you join, you mute your microphone so that it doesn't distract anybody. You can be writing your questions down if you have any. And when I'm done, you can ask your questions. And I will gladly go back and then review the question with all of us. So please, you have nothing to be worried about. Just make sure you understand what I'm trying to put across and the clues I want you to get. So please, that is very, very important for me. Okay. So she was prescribed with antihistamine drug that has no effect upon the central nervous system. So what drug are we thinking about? Like I said, this person is suffering from what? From allergy. And we know for people suffering from allergy, what comes to play? You are thinking of a mast cell. Mast cell. And you know these mast cells contain what? Histamine. When they degranulate, they releases what? Histamine. Histamine. And this histamine is what causes the vasoconstriction and then the itchiness and then the rashes. These histamines are what are causing those things. So over here, we want to give an antihistamine. That means something to prevent the histamine from what? Having its effect. Having its effect. And now when you look at all these options, definitely we are thinking of what? Loratadine. Loratadine. So your answer is what? A. Loratadine. Loratadine. It is actually an H1 receptor or H1 histamine. We have H2 and H1. This is actually what? H1. This is what? H1. So please note, this is what? Antihistamine drug. So your answer is A. All right. So during an operation, a patient got injection of muscle relaxant ditilinum. So, you know, during operation, we have to be cutting them in a way. Of course, you can't cut somebody who is whose cells or muscles are very, very what? Active. So these muscles need to be what? To be relaxed so that cutting will be made what? Possible. Great. So they say relaxation of the skeletal muscles and inhibition of respiration lasted for 2 good hours. For 2 good hours. Usually, we have a time duration for the muscle to relax for an operation to what? To take place. Now, when this relaxation exceeds the norm, then definitely there is a problem somewhere. An enzyme is definitely what? Deficit over there. So you need to know what enzyme they are what? Referring to or they are talking about. And usually in the muscles, what enzyme that we normally see, we call them pseudocholinesterase. Pseudocholinesterase. So these enzymes are found in the muscles. So when we inject this ditilinum, they actually temporarily work on this pseudocholinesterase to reduce its effects on the muscles. So the muscles will not be able to what? To react when you are cutting, or it becomes relaxed, technically speaking. It becomes relaxed. So when there is a problem with this pseudocholinesterase, what it means is that they are not sufficient enough to what? To function in the patient. They are not what? Sufficient enough to function. So that is why over here, because they've injected this ditilinum, this pseudocholinesterase needs to revive again and come back and start working and start constricting. But here's the case. They are still relaxed even at that time. That should tell you that that enzyme is deficient. That enzyme is what? Deficient. So over here, the enzyme we are talking about is called what? Pseudocholinesterase. Pseudocholinesterase. And of course, when it undergoes a process of metabolism, we now call it butyrylcholinesterase. Butyrylcholinesterase. So that's what over here, even if you don't see pseudocholinesterase, we can actually go in for what? Butyrylcholinesterase. They are all what? The same pathway, or they are all from the same pathway. So over here, quickly, we go in for what? B as our likely diagnosis, or our likely what? Enzyme which is deficient. Okay. So we have a 60-year-old patient who was admitted to the surgical department because of infection that is caused by a blue pus bacillus, also known as Pseudomonas aeruginosa. Pseudomonas aeruginosa. If you know your microbiology very well, you will know that Pseudomonas is a gram-negative bacteria. Gram-negative bacteria. So which is sensitive to penicillin antibodies, indicate which of the given penicillin has marked activity to this Pseudomonas aeruginosa. So definitely we are looking for a drug among these, all of them are penicillins actually, among these penicillin that work effectively on gram-negative bacilli. Gram-negative bacilli. And that is why over here, the likely diagnosis or the likely drug that we can use are what, or is carbamazine disodium. Carbamazine disodium. Of course, that's a broad spectrum activity. That's a broad spectrum, but it selectively work on gram-negative bacillus. Example is the Pseudomonas aeruginosa. Pseudomonas aeruginosa. Over here, we go in for what? For D as our likely answer. Okay. Please, as you are listening, when we are done, try and go through the pharmacology book if you have any and look out for these drugs. I am just giving you a general overview of the drugs and stuff like that. But the major work need to be done by you after I've given you what? The guide. Okay? After you remember, I'm not doing pharmacology, but we are just using to answer all the questions when it comes to what? So when you see the questions, you'll be familiar with them and easily you can answer them without wasting much time. All right. That was just by the way. So let's continue. We have a 45-year-old woman suffering from what? Allergic seasonal coryza. The same thing. So this person is what? Suffering from what? Allergies. So what do you need? You need an anti-what? Histamine, right? So this is caused by Ambrosia blossomin. What medicine from the stabilizer of adipose cells group can be used for the prevention of this disease? For the prevention of this disease. So again, you are looking for what? An antihistamine drug. An antihistamine drug. And what do you go in for? You go in for what? Ketotifen. This is actually second generation non-competitive antihistamine drug. I repeat, it's a second generation non-competitive antihistamine what? Drug. Antihistamine drug. So over here, you go in for what? For A as your likely what? Drug for the prevention of this seasonal coryza. Okay. What do we have? We have systemic amoebiasis. Do you remember a question on amoebiasis? Amoebic dysentery. Good. If you do, we said what drug is very, very sensitive to it. Of course, metronidazole. Metronidazole. So, based on your understanding, you know that amoebia is what? It's protozoa. So you need an anti-protozoa what? Drug to act on it. So definitely, you go in for what? Your metronidazole. So this question, few seconds, and you are done. You are done. Great. So let's continue. Always apply. Always apply. All right. We have a 38-year-old man who poisoned himself with a mercury dichloride. Mercury dichloride. And he's in what? In grave condition. What antidote are we looking for? What antidote are we looking for? So this is a metal intoxication or a mercury intoxication. And the antidote for, not just for, how do you call it? Not just for mercury, but for arsenic, for gold, for lead, basically for metals, we normally use what? Unitiol. 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 So in a question, when this person was abused or is working with, how do you call it? These occupational hazards, and there is, please, no video, no video. Someone is trying to, please, no video. Thank you. Thank you. No video. All right. Thank you very much, doctors. All right. So, like I was saying, any metal intoxication, you use what? Unitiol. If I were you, I'll be writing this down. Any metal, being it iron, being it lead, use unitiol. Unitiol. Mercury, whatever it is, gold, arsenic, whatever it is, use unitiol. And in some cases, even with what? Bismuth, bismuth, bismuth poisoning, you can still use what? Your unitiol. So here, your likely answer is what? Unitiol, which is E. E. All right. So let's move to the next question. So what do we have? We have a patient who is suffering from what? Insomnia, that means cannot sleep, caused by emotional disorder, and was prescribed with what? Hypnotic drug with tranquilizing effect. With tranquilizing effect. So what drug are they referring to in this question? What drug are they referring to in this question? So basically, they are looking for what? A hypnotic what? Drug. Actually, all of them can be. But the question is, with tranquilizing what? Effect. So you want to give a drug that will make the patient what? Calm. Okay. It will make the patient calm. At the same time, it will make the patient forget about what happened, for which she is what? Emotionally thinking about. For which he or she is emotionally thinking about. That's the kind of drug you need to give. That's the kind of drug you need to give. And that's why over here, quickly, you can go in for what? Nitrazepam. So please take note of that. Nitrazepam. Even something can even give diazepam. So please take note of all of these drugs. They usually end with the pam with tranquilizing effect. Okay, like I said, all of them are all these benzodiazepines, or they prevent convulsion and all of those things. So they are all hypnotic drugs. But the one with tranquilizing effect, that is, makes the person forget about his or her past, or make the person extremely calm, is the nitrazepam. When you are calm, of course, your sleep will come back. Okay. Good. So we have a patient who had gone through an operation. Guys, look at it again. Again, we said during operation, what happens? You have to inject what? Decomposition. Why? Because you want to relax the what? The muscles. And when you relax the muscle, that's when you can make your cuttings or your intubations, whatever it is. And I said, what enzyme comes to play? Yes, pseudocholinesterase. So you see, over here, without even going through all the questions, you already know your answer, because you have understood from the onset that this and this and this happens during decomposition. But let's continue. They said at the end of the operation, there was cessation. And the cessation of the anesthesia, the independent respiration wasn't restored. That means it continued, it prolonged. So which enzyme deficit prolongs the action of the muscle relaxant? Exactly. Pseudocholinesterase. As simple as that. Pseudocholinesterase. So quickly, you go in for what? Your answer. To be what? C. Yes, C. All right. Good. So we have the alternate usage of diclotizate, itacrine acid, and laxes didn't cause marked diuretic effect. Now, all these are all what? Thiazide what? Diuretics, okay? You know diuretics, that is allowing people to what? To pee a lot. So water to flow out of the system, that is what? Diuretic drugs, or these are diuretic drugs. And we use it for somebody with what? Edema or with hypertension, basically. Now, they said this person is having what? A marked peripheral edema. Marked peripheral edema. And they're saying the usage of these drugs did not really cause what? Much effect. Now, increased amount of aldosterone is in the blood. This is your clue to your answer. There is an increased aldosterone. And you know aldosterone is in the habit of producing more what? Sodium. Sodium. So there's more sodium in the what? In the body. And you know where sodium is? That's where water is. So sodium has the affinity for what? For water. And that is why, because there is a lot of sodium in the blood, the diuresis is not happening, or the fluid to escape into the outside world are not happening. So at the end of the day, we are still having what? The edema being what? Present. Why? Because we have what? The aldosterone there. So what do you do as a physician? You need to give anti-aldosterone drug, or a drug that will antagonize the aldosterone. A drug that will antagonize the aldosterone. And that is why over here, without wasting my time, you go for what? Aldosterone what? Antagonist, which is what? Spironolactone. Spironolactone. So here, your answer is what? Is B. Another name for this aldosterone antagonist is called what? Potassium sparing. Potassium sparing, meaning it will lead to the excretion of all this sodium, and as a result, water will be moving out of it. And again, it will preserve the electrolyte, which is what? Potassium. Now, you might not understand this properly, but if you start practicing, you know how important these electrolytes are. How important these electrolytes really are. They can cause arrhythmia. And that can lead to death of the patient. Yes, arrhythmia. Okay, so here we'll go in for what? Potassium sparing, which is what? Spironolactone. So here that answer was what? B. Okay. Now we have signs of gastrophy. When we say gastrophy, a problem with the mucosa of the stomach. Now, they say it developed in this patient with rheumatoid arthritis. You know, people with rheumatoid arthritis are normally given NSAIDs or non-steroidal anti-inflammatory drugs to help them with the pain. Now look at it. They said this person was treated with endomethacin. So that again confirms the drug treatment, which is what? Non-steroidal anti-inflammatory drugs. And if you know, so now, because there's a long use of this non-steroidal anti-inflammatory drug, it intends have a problem with the mucosal lining. Because you know that in the mucosa of the stomach, we have what we call prostaglandins. Now, when these non-steroidal anti-inflammatory drugs are being used, what happens is that it blocks what we call COX-1 and COX-2. COX-1 and COX-2. So these COX-1 and COX-2 are actually the enzyme or the pathway that leads to the synthesis of prostaglandins. I hope you are getting that. You're observing that. So it blocks the action of COX-1 and COX-2. And you know these COX-1 and COX-2 are the one responsible for the production of prostaglandins. And like I said earlier on, these prostaglandins are actually needed in the mucosal lining. So it protects the mucus of the stomach. So when you continuously use non-steroidal, you are telling the body that stop producing prostaglandins. And as a result, the lining of the mucus will become thin or will become bare, will be unprotected. No wonder this person is suffering from what? Gastropathy. Gastropathy, that means disease of the gastric layer. Disease of the gastric what? Layer. And when I say COX-2 and COX-1, I'm referring to what? Cyclooxygenase. Cyclooxygenase. So if I say non-steroidal anti-inflammatory drug like endomethacin is blocking COX-1, what I'm saying is that it is acting as anti-cyclooxygenase. Anti-cyclooxygenase. So if you want to give somebody non-steroidal anti-inflammatory drugs, you don't give it for long periods of time. Maybe 5 days, 10 days is enough. Because if you give it for long, this patient might even come with ulcer. So basically, your answer is what? Is D. Is D. All right. Great. So we have testosterone. And you know testosterone is a steroid, right? It is a steroid. And its analogs increase the mass of skeletal muscles that allows to use them for treatment of dystrophy. Now, due to interaction of the hormone with that cell substance, is this action caused? What they mean by, in what way do these testosterone, or with which receptors do these testosterones, generally put, steroid function? How do they interact? What is their mechanism of what? Of action? What is their mechanism of, or how do they go about with their what? Activity? So usually, it is what we call what? The nuclear receptors. That is how they interact. They interact with the what? Nuclear receptors. And these nuclear receptors are mostly sensitive to steroids. They are sensitive to what? To steroids, to thyroid hormones. So these are the major things that the nuclear receptors are very, very what? Sensitive to. Again, steroids and what? And thyroid hormones. Steroids and thyroid hormones. These are the two basic, of course there could be more, but these are the two basic means by which steroids and thyroid interact with other cells, or interact or carry about with their responsibilities through nuclear receptors. Through nuclear receptors. So here, quickly, we will go in for what? For A as our answer. Okay. Good. Okay. So what do we have here? We have a patient complaining of weakness, dyspnea, low extremities edema, or lower extremities edema. We have chronic cardiac insufficiency. What drug are you going to what? Prescribe? Now, this is a chronic heart failure. Chronic heart failure or chronic cardiac insufficiency. These can be used interchangeably. So what happens is that you want to give what we call what? A glycoside. Glycoside. Why do you have to give glycoside? Because glycoside will not make the heart to work extensively. Because the more the heart begins to work, the more problem it begins to what? To cause. The more problem it begins to what? To cause. So don't make the heart work what? Too much. Don't make the heart work too much. So usually, the drug of choice, like I said, glycoside, and the glycoside here is digitoxin, and that is used for chronic cardiac insufficiency. Chronic cardiac insufficiency. We have another drug for acute. So in case of acute, you are thinking of corglyconum, C-O-R, corglygen, C-O-N-U-M, corglyconum. So corglyconum is the drug of choice for acute cardiac insufficiency or acute heart failure. Acute heart failure. And for chronic, you're going for what? Digitoxin. So please take note of that. Propranolol usually is a beta blocker. And of course, it relaxes the heart and makes the heart also not function anyhow. It makes the heart beat slowly but effectively. But you can't go in for propranolol because this is a chronic state. It is a chronic state. In myocardial infarction and other things, we can use the propranolol. But in this case, we rather prefer the what? The digitoxin. All right. So your answer is what? Is B. Great. So we have a patient. A patient was on glucocorticoids. You know, glucocorticoids are produced by the what? By the adrenal glands. Glucocorticoids are produced by the adrenal what? Glands. For a long time, you see, he was on this for a long time. Now, discontinuation. Look at the question. Oh. Discontinuation. That means the person stopped using the medication. Discontinuation of usage causes what? Exacerbation of the illness, which decrease blood pressure, weakness. How can you explain this? How can you explain this? So this one is just right in front of you. This person was using glucocorticoids. For one or two reasons, the person has stopped using it. And we know glucocorticoids are what? Are from adrenal glands. So if it is not being produced and it is not being taken in, what happens? It means there is what? Insufficiency of adrenal what? Glands. Insufficiency of adrenal glands. So here, your answer will be what? Will be E. Your answer will be E. All right. Good. We have a patient complaining of dryness in the mouth, photophobia, that means afraid of light, vision valuation was admitted to the reception room, skin is hyperemic, dry, pupils are dilated, tachycardia, poisoning with belladonna alkaloid was diagnosed. Look at it. They said what? Poisoning with belladonna. So what is the drug of choice? So this one, they have already told you that this person is being poisoned with what? With belladonna. So you are definitely looking for what? The antidote for belladonna. And the antidote for belladonna is actually pilocarpine. So this should have been the answer. Pilocarpine. Because that is the drug of choice for belladonna intoxication or belladonna what? Poisoning. That should be the drug of choice. However, according to Krok, this is Proserine. This is Proserine. So like I said, you can go and check it out, but the answer is pilocarpine. However, according to Krok, it is what? Proserine. Maybe there's a better explanation to it. Fine. Other than that, this answer should have been what? Pilocarpine. Pilocarpine. Of course, we know that proserine helps to stimulate the intestinal peristalsis and the tonus of the urinary what? Bladder. Yes, but with this one, the answer should have been pilocarpine. However, like I said, Krok, it is what? Proserine. And please go for proserine if you see this question in Krok. If you see this question in Krok, go for what? Proserine. All right. So we have a 70-year-old who suffered from chronic bronchitis, was prescribed a medicine for cough. That is what? Codeine. So codeine is actually what? An antitussive drug. When we say antitussive, it means anti-cough. It is an antitussive what? Drug. And basically, it acts centrally. So basically, this one, you don't explain it further, but basically, it acts centrally. Also known as what? Antitussive. So here, your answer is what? Is A. Good. Aha. We say proserine increase skeletal muscle tone when given systematically. Halothane induces relaxation of the skeletal muscles and reduces proserine's what? Effect. Look at the two. One increases what? Increases what? Skeletal muscle tone. The other relaxes it. So what is the nature of proserine and halothane interaction? So you have a drug that is causing, increasing, another one causing what? Relaxation or decrease in skeletal what? Tone. What it means that they are indirectly functioning against each other. They are indirectly functioning against what? Each other. So this is what? Indirect functional antagonism. Indirect functional antagonism. So that's why over here, quickly we'll go in for what? For B. We'll go in for B. Now, when we say indirect functional antagonism, it occurs when the function or the action of one drug is opposite the other. But the drugs do not affect each other directly. They do not affect each other directly. So please take note. They do not affect each other what? Directly. Okay. So here your answer is what? Is B. Yes. Answer is B. All right. Okay. We have a patient with neurodermatitis has been taking prednisolone. Prednisolone is a glucocorticoid, and the person has been taking this for a very, very long time. Examination revealed high rate of sugar in the blood. This complication is caused by the drug influence upon the following link of carbohydrate metabolism. Now, you know the function of what? Glucocorticoid. What do they do? What they do is that they cause gluconeogenesis, or they activate what? Gluconeogenesis and lipolysis. Gluconeogenesis, you know, gluconeogenesis simply means what? Production of what? Of glucose from non-carbohydrate what? Substances. Do you get it? So this is what? Gluconeogenesis. Gluconeogenesis and lipolysis. So over here, you're going for what? For C. Because we are dealing with what? Glucocorticoid. Because prednisolone is a glucocorticoid or a synthetic glucocorticoid. So please take note. So that is what? C. Okay. So what do we have here? We have a 37-year-old patient suffering from obliterating what? Vascular endarteritis of the lower limbs. So when we say obliterating vascular endarteritis, we are simply referring to hardening of the vessels, or let me just simply put, in quote, atherosclerosis of the lower limb. Because normally when we say atherosclerosis, we are normally referring to what? The coronary what? Artery. That's what I'm putting it in quote. So this is what? Basically atherosclerosis of the lower what? Limb. And the person takes what? Phenylene. Now, because of presentation of convulsive disorder, he was prescribed with phenobarbital. Of course, you know what phenobarbital is. So withholding this drug caused nasal hemorrhage. Nasal hemorrhage. So what is this complication connected with? Connected with. So first of all, you must know that phenobarbital causes decrease in anticoagulative activity. You can write it down. Phenobarbital decreases anticoagulative what? Ability or activity. When we say it decreases anticoagulative activity, it means that if you give phenobarbital, the person will not be able to what? To clot. To clot. When we say clot, it might not be able to stop bleeding, or you cannot stop what? Bleeding. You can't stop bleeding. You can't stop what? Bleeding. That is what phenobarbital what does. And how does it carry out with its mechanism? It induces liver microsomal what? Enzymes. It reduces liver microsomal what? Enzyme, which is resulting in the increase in what? Metabolism and decrease anticoagulative what? Response. Anticoagulative what? Response. So basically, because of the increase or because of the convulsive disorder and the patient was prescribed with the phenobarbital, the patient started having what? The bleeding. The patient started having what? The bleeding. And how did this, what is this mechanism of action? It induces what? Microsomal what? Oxygenation in the liver. Microsomal what? Oxygenation in the liver. And don't forget, most of the coagulation factors are found in the liver. Most of the coagulating factors are found in the liver. So please take note of that. So over here, we can easily go in for what? For A as our likely complication or mechanism. Like I said, if we are preventing blood from clotting, definitely there'll be what? There'll be hemorrhage being what? Present. That's what there's what? Nasal hemorrhage. Nasal hemorrhage. Okay. Good. We have a 56-year-old patient who complains of thirst and frequent urination. Now, anytime you think of thirst, frequent urination, eating too much, what comes to mind? Yes, diabetes mellitus. But this person is what? 56. Okay, so look, was diagnosed with diabetes mellitus, and butamin was prescribed. What is the mechanism of action of this? What is the mechanism of action of this drug? So basically, this person is suffering from what? Diabetes. Excuse me, sorry. This person is suffering from what? From diabetes. And we know, since he's 56 years old, we're definitely thinking of what? Type 2 diabetes. We are thinking of what? Type 2. And in type 2 diabetes, what happens? We want to stimulate what? The beta cells of what? Of Langerhans. We want to stimulate the beta cells of Langerhans for this what? Patient. Okay. So basically, we'll go in for what? For C as our likely what? Answer. Why beta cells? Because they are responsible for the production of what? Of insulin. They are responsible for the production of what? Of insulin. So yeah, we'll go in for that. Okay. Okay, so we... Can you guys hear me? Yes, I think so. An elliptical remedy of a reflective type from H. cholinomimetics group was given to the patient for restoration of breathing after poisoning with what? Carbon monoxide. Carbon monoxide. So this is where your norepinephrine and epinephrine what comes in. So you want to ginger the person to breathe very fast because the person is already what? Suffering. The person is in dyspnea. So to restore breathing in an emergency case, because this is an emergency case. This is what an emergency what case. So usually in the ward or in the hospital, the drug of choice that we normally go for will be what? With loboline or will be loboline hydrochloride. Of course, some people can choose to go for what? Adrenaline, which can also what? Work. But when we have loboline, we'll prefer the loboline to the adrenaline. So please take note of this similar medication. They are all kind of what epinephrine that comes to just excite the brain to just start what restoring what respiration. You know, your how do you call it? Your center for respiration is in the what? It's in the medulla. It's in the medulla oblongata. So this drug effectively goes in there to resurrect any dead cell over there or anything that needs to what? To control respiration. That is where it is found. So here, quickly, we can go in for what? For loboline. Okay. Okay. So we have an aged patient complaining of headache, dizziness, quick tiredness, worsening of memory. Unannounced the what? Craniocerebral what? Injury. So what kind of drug will it give to boost this person's memory? That's what they're asking you in this question, technically. So what drug will it give to boost or to improve blood flow? Don't forget, the person have a craniocerebral what? Injury. So maybe there could be, reduced blood flow to the what? To the brain. That's why the person is having what? Dizziness. That's the person having what? Dizziness. So you are looking for a drug that can improve blood flow to the brain, a drug that can also help with what? With the memory, or will increase memory what? Stability. Will increase memory what? Stability. Will reduce what? Hypoxia. Will reduce what? Hypoxia. And that is why over here, you will definitely go in for what? No tropics. So here, you go in for what? No tropics. So A will be your answer. And of course, an example of a nootropic will be what? Piracetam. Not paracetamol. Piracetam or piracetam. 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 That will be the drug of choice. We use it a lot. That's why I can remember such a name. Piracetam. All right. Good. So we have a patient with frequent attacks of stenocardia, which was prescribed a Sustic Forte to be taken 1 tablet twice a day. At first, the effect was positive. Look at it. At first, the effect was positive. But on the second day, the attacks resumed. So how can you explain the inefficiency of this prescribed drug? What? Drug. So you need to know that anytime there is an acute, sudden decrease in response to a drug after it has been administered, that phenomenon or that term is called tachyphylaxis. I repeat. So tachyphylaxis is simply an acute, sudden decrease in response to a drug after it has been given. So we read that this drug was working when it was given, but again, it stopped working. That means that this drug is weakening in effect. So there's a quick weakening. There's a quick weakening. And there's a term that is used to describe such quick weakening of the effect of the drug. Tachyphylaxis. Tachyphylaxis. So here, your answer is tachyphylaxis. Tachyphylaxis. Okay. Good. They say a patient has taken the mixture prescribed by a neuropathologist for neurasthenia for 2 good weeks. The patient felt better but developed coryza, conjunctivitis, rash, inertia, and decrease of memory. But look at it. They said bromazine was diagnosed. Bromazine was diagnosed. So what should be prescribed to decrease these symptoms? Now, when we say bromazine, it simply means what? An intoxication of what? Bromide chloride. An intoxication of what? Bromide chloride. Or potassium what? Bromide. Usually it is potassium bromide or lithium bromide. Yes. Potassium bromide or lithium bromide. Now, if you understand biochemistry very well, we are going to, how do we give the antidote? We are going to look for a drug that can take up these bromide ions. Okay, that can take up these bromide ions. And what drug can we give? Of course, sodium chloride. Sodium chloride. The chloride will pick up the bromine. The chloride will pick up what? The bromine. As simple as ABCD. As simple as that. As simple as that. So this one, when the patient can just give normal saline. That is, when I say normal saline, normal saline to me means sodium chloride because it is salt. Sodium chloride is salt. So you give salt and the patient will be what? Will be fine. Patient will be fine. So here, you definitely going for what? For A. For A as your likely drug of choice. Okay. We have a 37-year-old man who was admitted to the surgical department with symptoms of acute, guys, look at this, acute pancreatitis. Now, every other symptoms is, of course, talking about the acute pancreatitis. But the question is, what medicine should be used first of all? What medicine should be used first of all? Now, if a patient is suffering from acute, give Contracal. If the person is suffering from a chronic, give pancreatine. I repeat, if the person is suffering from acute, you give what? Contracal. If it is chronic, you give what? Pancreatine. So basically, that is it for pancreatitis. So here, your answer will be what? A. Your answer will be what? A.